Good morning, I'm Professor Streb, and today we are looking at chapter 18. This is going to be your NUR265, NUR265. This is unit 9. We're continuing on unit 9, and this is chapter 18. The concepts that we're going to review today for this chapter are about hypersensitivity and allergies, autoimmune disorders, which is pages 349 to 359. And Lyme disease, which is on the pages of 359 to 360. So that's kind of where we're going to start. Let's just start with the priority and interrelated concepts. We're really talking about immunity and inflammation. That's what happens when your body has an allergic reaction. The immunity concept for this one, we're going to talk a little bit about lupus. And then when we talk about lupus, we're going to really talk about gas exchange and tissue integrity. But let's just kind of dig into this chapter. This might really help you understand a few things. When we think about a hypersensitivity, we think about an allergy. We're just talking about an overreaction immunity with excessive inflammation. It means your body notices something, right? If you kind of keep reading here, when you think about a hypersensitivity, you think about an allergy. There are different, phases like a type 1 hypersensitivity. You can go down and look at type 2 and the rest of them. But just want you to kind of understand that usually the target actions of your immune system are very appropriate. They get some kind, you get a cut, you get a foreign body in, your immune system really starts to increase the production of the immunoglobulin E, which is an antibody class. And then with acute inflammation occurs when the IgE responds to an antigen, right? Like pollen, it releases histamines, bradykinin, it has the vasoactive basophils, the eosinophils, the mast cells. We're talking about your white blood cells, right? How your body starts to go out there and start attacking any kind of foreign substance. That's all we're talking about, right? There's just a lot of things going on. It says an example of a type 1 reaction includes angioedema, anaphylaxis, allergic asthma. We know that certain times when you get stung by like a bee, or you get exposed to latex or peanuts or iodine, shellfish, any of that kind of stuff, that these and many other antigens will act like an allergen, and then your body starts attacking those. So it's important to understand that people who have latex allergies, they have risk factors that include having previous reactions to foods like bananas, nuts, and avocados. So understanding that certain things in the world can just elicit this hypersensitivity effect lets us understand we don't have to know why it occurs. We just know that sometimes your body starts releasing these immunoglobulins, and sometimes your body overreacts to things that other people don't react to. That's it. So I start thinking, if you know somebody with a bee sting, or somebody with latex allergies, or they had food allergies as well, and they eat those, what are we trying to do? We're trying to decrease the inflammatory response. We're trying to decrease the angioedema, right? We're trying to stop that swelling of the airways. So things like bee stings or anything else, epinephrine might be required. So that intramuscular injection of epinephrine is typically what we end up seeing. All right. So the most common vasoactive thing that we're thinking about is, as far as the amines are considered, is your histamines. We've all heard of histamines. We've heard of histamines, taking the histamine medicine. So a histamine results in these 5 cardinal symptoms of inflammation. And I want you to understand what that looks like. Inflammation typically presents with these 5 cardinal symptoms. Anytime you get inflammation, you get a cut, you get warmth, you get redness, you get swelling and pain, and there is some kind of decreased function. And these are caused by capillary leak. It could be nasal and conjunctival mucus secretion. So like sometimes your eyes water, sometimes you get pruritus, which is itching skin. You get erythema all over, which could be the redness. These are what we know happens when you get exposed to a histamine. So any kind of type, those are the histamines that we are really familiar with. I'm trying to tie the concepts together so you can see where we're at here. All right, let's go into the first part. Angioedema is a severe reaction that involves your blood vessels, your skins, your mucous membranes, and subcutaneous tissue, things of that nature. What ends up happening when you think about when you get exposed to like a pollen out in town, you get cedar or whatever, it can cause you to have like allergic rhinitis. It can cause, which is an angioedema effect, right? It's an angioedema response in that deep tissue problem. So that's what we're looking at. Why are we worried about angioedema? When we start thinking about angioedema and where it can occur really anywhere, We most often see it in your lips, your face, your tongues, your larynx, and your neck. What are we worried about with your lips, your face, your lungs, your tongue, your larynx, and your neck? It's an airway. So that's the part that we worry about most. Does it occur other places? Absolutely. We know that you can get angioedema that occurs in your GI tract, intestinally, so you can have abdominal pain, cramping, nausea, vomiting. There's all kinds of things. I think about Crohn's disease or things of that nature. I'm not saying it's the same, but it is an inflammatory response, and it can occur anywhere, like I said, even in your GI tract. So things for us to consider. We know that exposure to anything, chemicals, drugs, foods, whatever, can cause a problem. The most common drugs associated with angioedema are your ACE inhibitors, your angiotensin converting enzymes. So we know that when you take ACE inhibitors for your hypertension and NSAIDs, angioedema is one of those things that are very likely to occur. So, when we think about what that talks about, it talks about the mediator is a strong vasodilator and promotes deep tissue inflammation. That's what it is. All right, we know that Black adults, especially in the African-American population, have a higher incidence of angioedema and laryngeal edema when they take ACE inhibitors. And interestingly enough, we know that ACE inhibitors in that combination forms are what we typically prescribe to African-American people in the country because it seems to have the best effect. Unfortunately, it also has the higher incidence of angioedema. So it's important for you to understand, based on the patient you have, based on their characteristics and traits and their history and genetic makeup, that when people are on certain types of medications, we have to be very cognizant of the idea that about African-American folks and Black people in this country have a 5 times higher likely rate of angioedema with ACE inhibitors than the white counterpart. So very much important for you to understand. All right, so what can we do when people start having angioedema? We're always going to think about laryngeal edema. We're going to think about oxygenation. We're going to put on the nasal cannula. We're going to make sure we maintain this gas exchange. I like the way this book uses concepts. Gas exchange is what we're trying to do. How do we ensure that we have a gas exchange? Well, first we have to understand, because the reaction is mediated through antibodies, and there is a vasoactive anamine, think histamine, especially bradykinin, right? The most useful drugs are corticosteroids or epinephrine, because what do? They cause that decrease in inflammation. They cause a reversal of the inflammatory response. And if we're going to try to maintain gas exchange with laryngeal edema, we're trying to reduce that edema so we can have a clear airway. Indications for intubation is the presence of what? Stridor and the inability of the patient to swallow. Y'all, you're looking for signs and symptoms, which is great. But if you understand how the body works and you understand how these histamines are causing problems, you don't need to remember anything. Oh yeah, angioedema caused by histamine release. It causes vasoactive amines to do something. It causes it causes vasodilation there, right? And it's causing inflammation and it's causing swelling. So corticosteroids and epinephrine are what we're going to anticipate giving anytime we hear that stridor or we notice an inability of the patient to swallow. Here's a picture of angioedema, and you can see how it can occlude your airway if you're not careful. All right, drug therapy, we know this, we've kind of talked about it already, but I want to say here, once drug therapy is stopped, the IV access remains and the patient's closely monitored for 2 to 6 hours, right? What are we talking about? We're saying if you give a patient drugs, like they're receiving drugs through their IV, usually the agent that caused the angioedema has a longer half-life than the drugs used to treat it. So we have to kind of go back and monitor, is what we're saying. So we're saying that when somebody is receiving medication or whatever, and they end up, getting medication they don't need, what are we going to do about it? So it's saying that we should make sure if the patient's receiving IV medication, we want to completely stop the medication at this point, right? That's what we're trying to do. Stop, and the agent remaining in the blood can also cause angioedema to redevelop. So we have to think about when we're giving medications and we're doing something and we notice a reaction, we have to go back and think about how long it's going to be in the system. So once the drug therapy has been stopped, we're going to maintain our IV access. So as we're monitoring the patient for the next 2 to 6 hours, why are we monitoring for 2 to 6 hours? because the remaining histamines, the remaining stuff inside the blood can still cause angioedema. So even though we give you medication to treat it, just because we give you something doesn't mean we can stop. We have to keep back and keep looking and making sure that we don't have anything else. So stop the infusion, change the tubing, administer normal saline, but keep the IV access. All right. Anaphylaxis is a condition where the hypersensitivity creates all the blood vessels in the bronchial smooth muscles to do what they're supposed to do, dilate, right? So it causes widespread blood vessel dilation. So when we think anaphylaxis, if we have this widespread dilation, what does that cause? If I dilate, I decrease my pressures. So I have decreased cardiac output, because cardiac output is heart rate times stroke volume. My cardiac output goes down, my stroke volume goes down as my vessels start to dilate, because the pressure is not there and it doesn't have much of an injection, right? So we know that. And it causes bronchial constriction within seconds to minutes after an allergen's response, right? So think about this. You get exposed to an allergen. This anaphylaxis is your blood vessels and the smooth muscles of your bronchioles causing widespread blood vessel dilation. What happens when you cause dilation? It doesn't increase the pressure, but there is more blood flow coming to that area. When we have more blood flow to that area, what's it going to cause? It's going to cause you to have inflammation and swelling and edema and pain and warmth and redness. And that's what it kind of does. But it also causes this bronchial constriction, meaning it closes your airway up. So not only are you closing your airway by constricting the bronchioles, you're also bringing more blood flow that puts even more pressure in that area. So it's a double whammy. That's what we're talking about. So the major factor in fatal outcomes for anaphylaxis is a delay in the administration of epinephrine, because we know when we give epinephrine, it's going to cause bronchial dilation, and it causes some of that constricting to get the blood pressure back up as well. It's a really interesting thought when you really dive into it and kind of figure out what's going on. So what can we do about this? We need to teach our patients with a history of allergic reactions to avoid their known allergens. It's amazing how many people are allergic to shellfish or avocados, but yet you tell them they can't use it. What do? They want to eat it. So they'll still put their lives at risk trying to eat something they shouldn't. So it's important for us to really do the teaching. Make sure they wear a medical alert bracelet and alert all healthcare providers of any specific allergies, so we can kind of figure out how to counteract that as needed. All right, so that's the anaphylaxis part there a little bit. We'll kind of keep going. Interventions. What are we going to do? We're going to take action, because the patients will die. We're worried about what? Gas exchange first. That is our exemplary. That's what we're trying to get you to see here, is that when we think about allergic reactions and immune responses, we really are worried about that inflammation. And where are we worried about inflammation most? In the airway, because if you can't breathe, you can't live. So let's think about what we can do here. If an IV drug is suspected to be the cause of the anaphylaxis, like I said, stop the drug immediately. Do not discontinue IV access, because we have to restart an IV. Can be difficult, especially when these patients have that vasodilation. Now they're hypotensive. The blood vessels are no longer bounding, so it's hard to get an IV. That's why we don't do that. We change the IV tubing. We hang normal saline, right? That's what we have to do. So this is a very important step here. So much so that I like to copy it. This is how I take my notes too, y'all. When I study with you, I try to figure out things that are important. I know without a shadow of a doubt, this is what we have to do. It's how we're going to save lives. All right. Epinephrine is, and always has been, it probably will be for a while, this first-line drug for anaphylaxis. You can look at the dose and stuff, but it has to be repeated every 5 to 15 minutes as needed. The drug constricts the blood vessels, causing pressure to go up and increasing cardiac output. It improves cardiac contraction, which improves cardiac output, and it dilates the bronchioles, like I said. And that's really what we need to understand as it applies to this. All right, so keep moving on. We talk about antihistamines, and we can talk about different kinds. We think about the different drugs. So go back and look at the different types. We think about like dihydramine, like think about hydramines and things like that, right? So your antihistamines, this is your second line drug. We give it IV or IM for angioedema, for urticaria. Those are things that we know to be true. So make sure you understand certain drug classes and what kind of drug names fall underneath it. We think about Benadryl and things of those nature, right? Just understand what we're asking you to know. When a patient comes in and they're having any kind of allergic reaction, give oxygen to reduce hypoxemia and promote gas exchange. I can't keep saying it enough. We have to think gas exchange. We have to think about airway. So start oxygen 90% to 100% before the arterial blood gas results are even obtained, because we know it's going to be hard to keep our patient where they are. Elevate the head of the bed 45 degrees, unless they're having a hypotensive crisis, because then they won't freeze their brain, right? If they have bronchospasms, think about that. What do we give for any kind of bronchospasms? We know asthma. Give albuterol via the big nebulizer, Q 2 to 4 hours. We're trying to help reduce the inflammatory response. We're trying to cause bronchial dilation and vasoconstriction. We're trying to bring up cardiac output while maintaining an airway. These are the things that nurses have to consider every day when we're there. Here are just some of the disorders with autoimmune basis. So as we keep going down, they're talking about general autoimmunity. Your book doesn't say we need to really pop on this, but I like thinking about some of the things I know, disorders, what can happen. I know scleroderma is one of those things that I typically see. And when we think about this, we're thinking about patients who have difficulty swallowing. So when I think about autoimmune disorders and things of that nature, what are we really worried about? A lot of stuff. So we know irritable bowel, we know psoriasis, we know psoriatic arthritis and RA. Those are all things that we're worried about for sure. Ulcerative colitis, absolutely. But what's going to kill my patient fastest when the inability to swallow because they're starting to have inflammatory, swelling and edema in their airway. So just be cognizant of what your priority is. All right, systemic lupus is something big that we talk about. So they call it SEL, systemic lupus, right? And we're talking about what? Erythema. So we're talking about, we're just talking about the body's attacking itself, if you will. So the disorder, we have inflammation, we have the immune system starts to attack itself, multiple organs, multiple tissues. So over time, you have a progressive loss of tissue integrity because you have excessive inflammation. You have overreaction of immunity. It leads to organ failure. It leads to death. We know this to be true. That's what systemic lupus is, right? It causes this inflammatory effect amongst all of your body. So that's what I want you to think about here. So as we start thinking about how we're going to do something about it, the first part is understanding what causes it, who's at risk, things like that. We know there's a genetic connection. We know that's very, very strong. But we say that the origin for susceptibility has not yet been clearly identified, if you will. However, we know that there are triggers. So I want you to think about the triggers for the expression of SEL is a genetically susceptible adult, and it includes certain things, right? So certain adults will get this. Not all adults and not all people will end up with lupus, but infection, injury, drugs, hormones, exposure to environmental substance like UV light. These are triggers that we know if you're susceptible to getting lupus, that when you get an infection, when you have an injury, when you start taking drugs or have hormone therapy, or you get a lot of UV light, it can cause an exacerbation or first time, signs and symptoms, if you will. It could be your initial attack. So what causes it? We know that there are auto antibodies that are circulating and they attack your tissues. It causes this class 3 hypersensitivity, which you can go back in your book and look about. And it causes the formation of immune complexes that do what? They precipitate and deposit in various tissues, resulting in degrees of impaired tissue integrity. So you'll start noticing with people with systemic lupus, you're going to see a lot of skin abnormalities as well. You're going to see swelling in certain areas. So we're going to talk about that. You really got to get in the book and do the work. You have to start thinking about, in general, what's going on. It says compounding this general problem, blood vessels are major targets leading to chronic inflammation in the vessels, which reduce perfusion to organs and increase the risk for injury and permanent damage. That's what I want you to understand. What does lupus cause? It causes the blood vessels to become chronic. It causes chronic inflammation in the vessels, right? Inflammation in the vessels, which reduces blood flow and perfusion to the tissue. That's why we start seeing a lot of the tissues, right? We start seeing a lot of organ problems. Any and all organs and tissues may be affected. The most common cause of death are kidney disease and cardiovascular impairment. Why? Because what's going to kill you fastest? When you can't give your body the nutrients and the oxygen it needs to survive and the energy, or if you have kidney disease and you can't get rid of all those toxins, they will kill you fastest. That's why lupus is such an important thing for us to understand, to identify it, to help prevent it, to help keep it at bay, if you will, because it is going to cause this organ damage. All right, we know that women, you're 10 times more likely than men to get this. African-American women, or African-Americans in general, compared with whites, 8 to 1. So if you're an African-American woman, your exposure to this, or you know, your thought to this, your likelihood of having this impact your life is much higher. It's interesting, it says it's rare in Africa, it's more here. It's also higher in most populations of non-whites. What we start trying to think about that is, we know that it's commonly diagnosed in women 30 to 44 years of age. The overwhelming prevalence of the disorder is during childbearing age. So they think there's a strong potential to estrogen for these higher triggers. So that explains why women are more likely than men to get it. And it probably has something to do with, you know, genetic makeup. If you start thinking about African-American women in this country, I'm sure there's that connection. I don't know what it is, but I like to just be aware of anything that we as nurses can say, okay, based on your rate, based on all of your history, you are more likely to experience this. So as my patient, I'm always going to be on the lookout for that. We're not trying to say anything here. We just want to make sure we understand what that is. So women will need to be determined. Think about this. If it's strongly related, if one of the potential triggers are going to be towards childbearing and estrogen, right? It's important to talk to these women about, do you want to have a child? Is pregnancy really that wise for you? Is this something in your future? We need to have that real conversation with women of childbearing age to say, if you have a child, it is likely, especially if you have lupus, that it's going to cause severe issues. So it's nothing that we're going to decide for anybody, but it's something that we really have to think about with our patients so they can make an informed decision. All right, just want you to go down and start thinking about some of the key features. This red macular facial rash over your cheeks, we call it like a butterfly shape. If you go down and look here at the pictures, you can kind of see what that looks like. That's more of a systemic inflammatory response. So there we go. Sensitivity to sunlight. So we know photosynthesis, they get rash when they go outside. Pericarditis, pleurisy. We start thinking about the inflammatory effect around the heart, and then the fluid that starts to fill the heart around it. Kidney changes. You might see cast and protein in the urine. These are signs and symptoms that there's some kidney damage. We're looking for anemia. It's most common. We're looking for leukopenia, the decreased white blood cell count. It's just the way the body starts doing this thing. And then the presence of anti-nuclear antibodies. So these things could really be popping up, and we could see those anywhere in a test question or in just the history. When I say test question, your biggest test question is every day when you walk into a patient's room. So understand the signs and symptoms you should be aware of and looking for, so you can identify when somebody has lupus, and so you can start kind of, you know, with the interdisciplinary team, you can work collaboratively towards these patient-centered goals. All right, there are 11 common changes associated with lupus, and you should probably kind of go look at those. I'm not gonna get into all of them for you. You can go back and look at those. Right, you look at the key feature box. It tells you a lot of what you need to know here. But the patient is likely to present with high fevers during exacerbation because they are having an autoimmune response. Still look for infection. Still be aware of what signs and symptoms of infection look like. So that is lupus for the most part. And if we go down a little bit, we can start thinking about the drugs, right? So with these patients, we had to think about expected outcomes. We had to think about interventions. A lot of the drug therapy that we're going to talk about involves these combinations of immunosuppressant agents and selective immunosuppressive agents. So we know that we're going to do something to try to do that, right? Corticosteroids like prednisone are the cornerstone. So we understand how corticosteroids, go back and think about your endocrine system, think about your adrenal glands, think about your salt, sugar, sex, steroids. These are your glucocorticoids, your mineralocorticoids, think about cortisol and think about your corticosteroids and how they impact the body. We know that steroids do what? They decrease inflammation, which is fantastic. Common side effects though, man, if you've ever taken cortisol, cortisol is something different, right? So it can cause acne and sodium and fluid retention, hypertension, all of this, sensation of nervousness. Difficulty sleeping is one that I didn't even know existed. But man, when I taken it once, I couldn't sleep. I felt like I was on speed or something. Like it just wired me. I couldn't do anything. So it did cause me to have difficulty sleeping, things of that nature. Just be aware that we have to teach our patients this. The most important precaution to teach patients taking these long-term corticosteroids is to never stop taking your drugs abruptly, because it can cause that adrenal crisis. That's why I went back and said, think about your endocrine system. Think about how the pituitary gland releases ACTH and tells the adrenal glands, hey, produce more salt, sugar, steroids for our body. That's why if you stop it, it can cause your body to have this acute adrenal crisis, which can be life-threatening, and we don't want that. All right, just another one that I saw here, your anti-malarial drugs, hydrochloroquine. I know we've all heard that in the news here recently, but it is one of the things. It's a standard drug therapy for people with lupus. Just be aware of what that looks like. It may not respond to other therapies, so they might give this hydrochloroquine. It's just something that we have to know. But this drug decreases the absorption of what? Ultraviolet light by the melanin-containing skin. So it's just a major complication of this drug is the toxicity to retain of the retinal cells. So we think about retinitis. Teach your patients who have this medication to have frequent eye examinations, because what's it going to cause? It can cause damage to your retinas. You don't have to know everything, but we know that as a person has lupus, they're going to be on corticosteroids. We need to think about how to teach about that. We need to know they might be on these anti-malarial drugs like hydrochloroquine, and we need to think about their retinas. So they have to know, before starting this drug, and every 6 months, you need to have your eyes examined with visual field testing so we can see what your baseline is, and we can determine if you're going to have any adverse problems. All right, some lifestyle changes. We need to talk about these people who have lupus. So patients with lupus, how do we prevent more frequent flare-ups? We're not going to change it. We're trying to figure out what we can do. Changes that focus on managing fatigue, things of that. Avoid exposure to UV sunlights. Avoid prolonged exposure, and think about not just sunlight, but other forms of ultraviolet lighting. There are all kinds of stuff. Fluorescent lighting. So even, something that we don't even consider sometimes, being in the house. You have to wear long sleeves, large brimmed hats when you're outside. You have to use your SPF 30. Encourage even cosmetics for the women who have this butterfly. If they're going to put makeup on, make sure it has an SPF component to keep them from, retaining more of that. All right, and the last part of this chapter talks about Lyme disease, and Lyme disease is interesting because I don't know that it's not exactly autoimmune if we're going to talk about it, but we'll get there. We know that Lyme disease is caused by this disease here, right? It's a disease specific. I'll let you pronounce it the way you want to, but we know that it's most commonly spread and found by infected deer ticks, which are also known as black-legged ticks. So if you know ticks in North America, we know that these vectors are what spread it the most. So we have to be aware of people in the country, people out hiking, people in areas where ticks are more prevalent. That's what we're going to talk about. All right, so we're going to talk about tissue results. What happens is the tissue results of the chronic nature of this continuing immunity that attempts to eliminate the invading organism. What are we talking about? We're saying that this disease is not truly an autoimmune disorder. It's not caused by, but because the antibodies are generated. It's just the way that your body has a continued inflammatory response that attempts to eliminate the invading organism. So it's trying to fight off Lyme disease. Your body gets Lyme disease. Your body's trying to fight it off. It just can't. So you have this chronic nature where your body's continuing this immune response, this inflammatory response. And that's why it's kind of classified as an autoimmune disorder, even though it's not truly an autoimmune disorder. It just causes that continual inflammatory immune response. So we have to start thinking about in the early stages, this localized stage, how do we know that somebody might have had exposure? We look for this this erythema, we look for these round, oval, flat, or slightly raised rash with a bullseye pattern. That's a good indicator that they might have got bit by a tick, specifically an infected deer tick. There's pain, there's stiffness in the muscles and joints, that rigidity. So we're looking for signs and symptoms that might clue us in that the patient was bitten by a tick and that they might have been exposed to Lyme disease. Once we determine this, we know that antibiotic therapy, doxycycline and amoxicillin, are the prescribed drugs during this uncomplicated stage for 14 to 21 days. So your antibiotic treatment choices, 2 to 3 weeks. It is long, it is hard, but we have to do this. The patient may develop carditis with dysrhythmias, dyspnea, dizziness, palpitations. It happens, right? It can cause central nervous system disorders like meningitis, Bell's palsy, that facial paralysis, peripheral neuritis. It is a heck of a disease. Severe disease causes, you need IV antibiotics. Like I said, there are certain ones and they're given for 13 days. So it depends on where we're at. Treatment of choice is going to be doxy and amoxicillin for your uncomplicated initial, that's a 14 to 21 days. But then IV antibiotics, you think about just think about the different drug classes. I'm not going to get into different names, but that's given for at least 30 days. So we're looking at how you identify it and what you can do to teach it. So that's where we're at in that chapter. We're going to keep moving on. We've done chapter 17 earlier. I did chapter 18. Let's go into chapter 27 and 32 at this point and just keep going right on down. So we'll go to chapter 27 so we can keep going on the stuff that you need to do for your exam coming up here shortly, for exam 4, your final exam. So let's get into chapter 27. If we look over here, it says chapter 27, NUR265, unit 9, chapter 27. So this was earlier, but this is what we're doing now. We're going to go down to page 553 to 554, and we're going to look at non-infectious lower respiratory problems and lung transplant. So we're really talking about lung transplant patients here in this chapter. Like I said, it's important for us to understand the page number because we've already been in here before. We've already looked at other stuff, right? I'm supposed to say NUR265. I'll put the units there later, but that's not where we're at today because we've already done chest tubes. So what are we looking at? 553 to 554. And I will scroll down if you need a recap. Go back and look through your book again. This is all good information. It never hurts to go back and re-investigate anything that doesn't make sense as you're reading. I'm just going through and scrolling because this is what you have to do to be successful in nursing school. You have to study, you have to focus on your exam, and you have to go back. And any concepts that don't make sense to you, you have to invest in yourself and your education because your patient is reliant upon you. All right, so we're talking about lungs. We're talking about surgical management of lung cancer, right? Or lung disease or lung something. Surgical management of a patient with, let's just say in this case, cystic fibrosis, what they're talking about. I don't want you to get complicated. I don't want you to get stuck in the cystic fibrosis area. That we're not talking about that. We're just talking about lung transplant in general. So patients who require a lung transplant, that's what surgical management is. Transplants can extend your life from 1 to 5 years with an average of about 7 years. So this is not a permanent solution. It is a buying you time solution. And hopefully we can get more. You can get a transplant later. I mean, it is what it is. So we're thinking about preoperative care. Think about the patients. It depends on what kind of patients are going to come in for a lung transplant. So recipient and donor criteria, it varies. It depends on the person. So I don't get into it very much, but what we need to think about recipient criteria, you have to have severe irreversible lung damage. To be a recipient, you have to be going to die, basically. Your lungs aren't going to heal. You think about life expectancy, but you have to be well enough to survive the surgery. So common exclusions, if your patient has cancer, if they have HIV or AIDS, irreversible heart, kidney, liver disease, they're not going to live or they're not going to have good outcomes, if you will, with the surgery if any of these exist. So, you need to be aware of what kind of patients are able to have surgery and who are excluded. When we think about the priority nursing thoughts here, when you think about lung transplant, so before surgery is teaching the patient the expected regimen for pulmonary hygiene to be used in the period immediately after surgery. We need to start thinking about what we want them to do the minute they come back. That's what we're talking about. All right, post-operatively, the patient is going to be intubated for at least 48 hours. They're going to have chest tubes and arterial lines so we can look at wedge pressures and make sure everything's going up. So what we're going to focus on here, the major problems after a lung transplant are going to be bleeding, infection, and transplant rejection. That should make sense for most of us. We understand bleeding and infection. This might be new to some of us, is the transplant rejection. So we need to be aware of what that looks like. So anti-rejection drugs are going to be given immediately. And this combination therapy of anti-rejection drugs is used for the patient's life duration. So as long as they stay alive, they're going to be on this anti-rejection drug medication regimen. Corticosteroids are avoided in the first 10 to 14 days after surgery because of the negative impact of the healing process. What do corticosteroids cause? Anti-inflammatory response. After surgery, we need inflammation. We need that influx of macrophage and different blood cells, red blood cells, white blood cells, erythropoietin, right? We need to clear damaged cells. We need to cause that rebuilding of better structures. So when we give corticosteroids immediately following surgery, in the first 2 weeks, we have a negative impact on that healing process. So while, yes, we're trying to reduce rejection, the anti-rejection drugs are good for that, and then corticosteroids for inflammation are going to be held off to a later time. That's all we have to talk about when it comes to that, really. So let's go into lung cancer then, and just think about what lung cancer looks like, just slightly. I want you to know when a patient has lung cancer, this might be one of the things that require them to have a lung transplant, right? Just something to be aware of. I was reading the books, I always do. I know that when I think of lung cancer, what always comes to mind is this rust-colored or purulent sputum. Consistent findings in patients with lung cancer. They will have a rust-colored, bloody type sputum that comes out. So I just want you to be aware of that as it's something that's super important. And we're going to move on. You already did chest tubes last time, so I'm not going to get into that. But yeah, that's where you're at. Let's move on. We were just in chapter 27 with lung transplants. We're going to go to chapter 32 and look at these pages. I keep going back to the syllabi, the syllabus, because I want you to understand what's required here. It's important for you to know how to use your syllabus in order to study. It's important for you to take good notes because it's easy to get confused. Like I said, you can see that we've already been in this chapter when we were in cardiac. Now it's unit 9. We're back in chapter 32 with these concepts. And we're really going down just to page 693 and 694 to think about heart transplants patients. So 693, 694. It's a lot. You got to scroll down. 693. You can go down here and do it this way. You can go down here and type in the page number if you would like. Oops, I went too far. We can just go here and type in 693. If I could actually type, that would actually be beneficial. So we're gonna look at that real quick. There we go. So 639 is where we're at here, and we're gonna go here and look and see. Give me 1 second. All right, so for this chapter, we start on 693, and we're going to talk about heart transplants. Much like lung transplants, there is criteria that you have to meet prior to being considered for heart transplant. And while we're in this, in this chapter, we do talk about cardiomyopathy, and it's one of the many reasons somebody might need a heart transplant. We're not focused on the disease. We're just talking about the actual transplant itself. So make sure you know the criteria. Patients must meet these criteria for heart transplant. They have to have a life expectancy greater than a year. They have to be younger generally than 65. Need to be on the New York Heart Association class 3 or 4 list. Normal or slightly increased pulmonary vascular resistance. It can't be anything wrong with the heart. You can't have this vascular resistance, meaning if you have a lot of vascular problems, if you put a new heart in, it's still going to get hypertrophic because it's fighting that resistance. Has to be an absence of active infection because that's not going to go well for you. And you have to have psychosocial stability, meaning if you're on any kind of antipsychotic meds or anything like that, that you have to be on those prior to being a candidate for heart transplant. So there's a lot going on here. You can think about your pre and your post-op stuff. So post-operatively, we're going to worry about a few things. For me, when we think about post-operative, of course, there's going to be the same things we always talk about, perfusion, cardiac output, the things that we already know. But specifically with a heart transplant, we're looking for signs and symptoms of heart transplant rejection. Let's just be honest. Shortness of breath, fluid gain, bradycardia, hypotension, AFib, decreased activity intolerance. What's that sound like? Heart failure. Signs and symptoms of heart transplant rejection are going to look a lot like heart failure, because when your heart fails to do a job, it looks like heart failure, because truly a heart transplant rejection is still heart failure. So it's not going to be anything crazy looking. It's going to look like heart failure. Be very careful about infection though. So think about hand washing, think about aseptic technique, because these patients are going to be immunosuppressed. Why? Because they're on anti-rejection drugs, and we're trying to decrease the immune response so that the rejection does not occur. So infection is the major cause of death and usually develops in the immediate post-transplant period or during treatment of acute rejection. So that is where we at with this, and that is where we're going to focus, and that is where we're going to remain on this journey. All right, so that's it. That's the rest of that chapter. We can kind of move on from that one, and we can go to the end of the chapter. Go back to our syllabus. We did chapter 32. Now let's move into chapter 53. And we're going to do all of these together. So we'll go right into chapter 53 next. It's an interesting, this whole entire unit is kind of interesting, 9, because of the way it's spread out across the board. You can start seeing that here on this one, chapter NUR265, unit 9, chapter 53, we're going down to what? Liver transplant. So 1171 to 1174. It's interesting that they're all over the place, because as you can see, these transplants, they're all over the place. You don't get to decide what we study, what happens in the body, things of that nature. But I want you to understand that most of these things kind of look the same. They're inflammatory responses. They're immune related, where the body is coming in to do its job. It's fighting off things we're not supposed to have in our body. We're not supposed to have somebody else's kidney or their liver or their heart. Your body recognizes that, and it has an immune response. So let's just kind of go down here. Liver transplant. What can cause the need for a liver transplant? We already know cirrhosis, which is scarring of your liver, making your liver no longer effective, is the most common reason for liver transplant. And we know that cirrhosis is caused by a lot of stuff, but a lot of times it's going to be alcohol induced. It could be non-fatty liver disease. Other common causes, hepatitis B and C, bile duct disease, liver disease, autoimmune, alcohol liver disease, fatty liver disease, the things I talked about. But we understand what cirrhosis is. So these are the patients who are probably going to be most likely to need a liver transplant. I only say that because I want you to be aware of what patients to look out for on an exam and in real life. Patients who are not considered candidates, this should be a reoccurring thing for you. Severe cardiovascular instability. If I don't have good cardiovascular perfusion, I'm not going to perfuse my liver anyway, so why do it? If I have severe respiratory disease, I'm no longer going to perfuse my liver, so why do a transplant? Metastatic tumors, they are going to metastasize into my liver, and it's going to cause liver failure. So it starts making sense. Or if you have the inability to follow instructions, like you don't have your psycho, you have a psychotic break, you're not following your medications, that kind of stuff, that could be a problem. All right. Candidates with the highest level of acuity receive the highest priority. So if your liver is functioning well enough, you're going to be on the bottom of the list. We know people who need it the most are the ones we're going to give it to most. So the donor liver is transported to surgery in a solution that preserves the organ for up to 8 hours. We know that to be something. We know that when we have live donors, it's usually better. I mean, we can do stuff like that. I just want you to be the diseased liver is removed from the incision, and they go from there, right? Incision where? Decision, they're going to remove the liver from an incision in the upper right abdomen. Cool. That leads me to down here, where signs and symptoms of rejection also include pain in the right upper quadrant or flank, because that's where the liver is located. I'm just giving you ideas. I don't want you to try to memorize where the pain is. I want you to think about the process when they actually go in there and cut out your liver and put a new liver in. Where are they doing that? So if you understand where this occurs, when you start thinking about transplant complications, the most common complication is an acute graft rejection, infection, and bleeding. We need to be on the lookout for that. That's why this nursing safety priority box, QSIN, once again, says, hey, look for signs and symptoms of rejection. They include tachycardia and fever. It makes sense because we're thinking about the immune response. Pain in that area, that's where we're having the rejection. Why is it painful? Why is it being rejected? Because of the immune response. When the immune system starts taking over, it causes an influx of fluid and white blood cells right? It causes the inflammatory response. As inflammation happens, pain ensues. That's why patients with a graft rejection often complain of right upper quadrant pain. It's kind of cool to think about, not the actual, the person, but what we as nurses need to be on the lookout for. All right, so I just want you to be very, very aware of what that looks like. All right, infection is a really potential, it's a potential threat, and it's another huge potential threat when you think about transplanted grafts and the patient survival. We keep saying transplanted grafts because you don't necessarily get a whole liver, right? Liver tissue can regenerate itself. So when we do liver transplants, they will graft sometimes a portion of a liver, and then that new liver will replicate, it will proliferate, and it will cause more liver tissue to help you there. So think about when we say graft. I just want you to be aware of what that looks like. Common infections include pneumonia, wound infection, urinary tract infections. We know that these opportunistic infections arise because these patients are on autoimmune suppressants type drugs to prevent graft rejection. So it's a double-edged sword. We need to keep your immune system at bay so it doesn't reject the graft or the transplant when we think about liver, kidney, and heart. But also because of the drugs, opportunistic infections will rear themselves. So after the first postoperative month and things like that, we have to think about infections and parasitic infections and things. We also know that latent infections, what do the latent infections mean? People could have tuberculosis where it's in their body. They could have herpes simplex. They could have, shingles. And these things can be reactivated once you have a transplant because your immune system is so low, and that's what's going. We know that women, Hispanics, and patients with less than a high school education are most likely to be readmitted with transplant complications. Why? Because unfortunately, socioeconomics still impacts women, minorities, and people who are having and we say less than a high school education, typically it's a money thing. So we know this. It's not that people are ignorant, it's a lack of resources. Maslow's doesn't allow you to focus on other things like trying to stay healthy when you can't focus on your basic needs. It just makes sense. All right, your primary healthcare provider is going to give a broad spectrum antibiotic as a prophylaxis during and after surgery. We're trying to prevent those infections because you're going to have a lowered immune system, and that's why we do this. Nursing is not near as complicated when you understand why, the why. Quit trying to memorize stuff and figure out the why. For the patient who has had a liver transplant, this is nursing safety priority, QSIN. Monitor for temperature frequently, per protocol. Report elevations. Think about abdominal pain, distension, rigidity. All of these things are indicators of what? Peritonitis. And peritonitis is a huge thing that we're looking at. So report signs also of clotting problems. Think about blood oozing from the catheter, petechiae, ecchymosis. Why? Because we have to report what? Clotting problems, because it's the liver. And we understand that the liver is directly related to what? Again, I want you to keep thinking about the why. Think about clotting factors. Think about vitamin K. Think about all of the things we have to understand with the body to understand signs and symptoms. Quit trying to memorize stuff. Go back, invest every single time. When you read clotting and you don't understand why clotting is important, go back up in this chapter, go read liver again and see what clotting factors and how the liver impacts clotting. You'll never have to go back and memorize. You'll always know based on what's going on there. All right, acute graft rejection, right upper quadrant pain. I've said that so many times. Diminished bile drainage. So think about bile color. Think about increased jaundice. This looks like what? Liver failure. You don't have to memorize everything. Just understand what's happening. If the graft doesn't take and the patient's already having liver failure, then they go right back to liver failure. So go back and look for that kind of stuff. The increased right upper quadrant pain now with distension and guarding. That's right. Inflammatory response, infection causes swelling. Swelling automatically causes pain. Now we start thinking about stuff. Distension, guarding, because of bile leakage, abscess, whatever you want to call that. Just be aware of the why and you don't have to memorize so much. All right, so that's it with chapter 53. We got these 2 chapters left. We're going to do chapter 62 and 63 and finish this off. So let's go to chapter 62 now in your book. There's a lot of chapters, y'all. I know. I'm just trying to keep it organized for you. So here we are back at chapter 62, and we're talking about concepts of patients with kidney disorders, nephrotic syndrome, page 1362. So we're just going to go on down here to 1362. You already know that's where I'm starting, right? That's what I do. If we think about this, just want you to understand what nephrotic syndrome is. So what is nephrotic syndrome? Immunological kidney disorder in which the glomerular permeability increases, so large molecules pass through the membrane into the urine and are excreted. We're saying that's not what's supposed to happen. Your kidney is not supposed to have this permeability that it lets large molecules pass through. It's supposed to be very, very tight and not permeable, so it can catch what? Impurities. As blood flow and fluid goes through the kidney, that tight filter, if you will, filters out all the abnormalities. So when we have acute nephrotic syndrome, the process causes massive loss of protein into the urine, edema formation, decreased plasma, albumin levels. We know what albumin does. That is something we need for protein and healing and all these other things. So when you have nephrotic syndrome, some of the signs and symptoms are going to be massive proteinuria, hypoalbuminemia. I can't say that word right now for whatever. You have lower levels of albumin in your body. It should make sense. Edema, we talked about swelling. I just want you to be aware of what this looks like, because it does allow certain things to pass through, and it allows them to be excreted, and you shouldn't see that in your urine. So just want you to go back and think about, like I said, what it looks like and what we're going to do. So we think about when you have the most common cause of these changes, it's altered immunity with inflammation. Once again, y'all, when your body starts attacking itself and it causes that inflammatory response, it decreases blood flow and causes tissue changes. We talked about that at the very beginning of all of this. So I want you to be aware of what it causes. The main feature of nephrotic syndrome is increased protein elimination. We know that because we have massive proteinuria. With severe proteinuria, look at the numbers. I don't know if they'll be there, but we know a 24-hour sample is going to be necessary. So make sure you can teach that. When you do a 24-hour sample, you throw out the first collection and you do the rest until the very end. We're just making sure we understand protein is going to be a huge thing that we have to assess for. Patients will have low serum albumin levels, less than 3 grams per deciliter. We know that they're going to have high serum levels of lipids. They're going to have fats in their urine. They're going to have edema. They're going to have hypertension. It just starts making sense. The renal vein thrombosis often occurs at the same time because of problems. That's not so important. I just want you to understand what the hallmark signs and symptoms are, this elimination of protein. Assess the patient's hydration status, because why? Vascular dehydration is very common. If plasma volume is depleted too low, we know that the kidneys are going to go into an acute kidney failure. That's what happens. That's all acute kidney injury is. We have to avoid that, and it can be avoided if we have adequate blood flow. Go back to what we talked about with anything about the kidney. Patients who are well hydrated don't have kidney problems, typically. So make sure you're paying attention to what your role is as a nurse, and you won't have to struggle very much. All right, last chapter here, and we'll go back here. We're on chapter, there we go. We're on chapter 62. Let me pull that up there. We're on chapter 62. Now we're going to go to chapter 63. I'm sorry, we had the nephrotic syndrome. Now we're going to go up to chapter 63 with the kidney transplant, 1405 to 1409. You might wonder why I didn't go to that one directly. I like to go in sequential order. We did go through 3 different transplants already with the liver, heart, and lung. This is just yet another one. Here it's talking about what we need for unit 9, and it's just pages 1405 to 1409. So we can go ahead and type in 1405 and get to that page. With 1405, we're talking about chronic kidney disease. Once again, I just want to go back and look and see what that looks like. We're talking about chronic kidney disease, kidney transplants, what we're really talking about. So some of this, if you look at the date, I just did this recently, going back to look at it, we're talking about 1405, 1409. What do we need to be aware of? None of that. Right here on this page, it says kidney transplant. Patients who need kidney transplant are the ones who are on dialysis. They're not going to be on dialysis, but we know that dialysis and kidney transplant are life-sustaining treatments for people with kidney disease. You have to do something. If your kidney fails, you have to fix it, right? We can do dialysis in the meantime until you get a kidney transplant, but a kidney transplant is what you're going to need probably to help. But I want you to know that kidney transplant is not considered a cure. Each patient will have to have more later on, right? If their body is able to maintain this. So go back to the same thing we talked about. What makes you a candidate for a transplant? Have a reasonable life expectancy. If you're going to die within the next year or two, there's no reason to give you a kidney because you're probably going to die anyway, right? You have to be medically and surgically fit to have a seizure, have surgery and undergo a procedure. That's what we're talking about. Absolute contraindications. Once again, active cancer, current infection, active psychiatric illness. It's not under control. You're a substance abuser. You're non-adherence to your dialysis, your medication treatment. If you don't care about yourself, we're not going to give you a kidney for you to ruin again. So it's going to be imperative on these exams for you to understand who is a likely candidate, who is not. What are some of the things we're worried about? So organs from living donors have the highest rate of graft survival. Once again, because that healthier donor, the actual organ has no cold ischemic time. The reperfusion injuries are less there because if I take it right out of one patient and directly implant it into another patient, it has the greatest chance of survival. Donors must be healthy enough to undergo the procedure and be over the age of 18. So that's what a donor has to have. You can look at blood types if you want there. You can go back and look. I don't think we need to talk a lot about that, but if your teacher told you to look at it, go back and look at it. Urological management is essential if you want your graft to take. So a urinary catheter is always going to be placed in your patient because we're going to do strict urine outputs to make sure we understand that you have good kidney production, you're micturating and you're getting that output, but also to decompress the bladder. If we don't decompress the bladder, we're going to stretch on the sutures. We're going to have the ureter attachment sites on the bladder could come unhinged, and now we could cause issues there as well. So we want you to pay attention to what you can pay attention to. Your patient just had a kidney transplant, a graft. An abrupt decrease in urine output may indicate that there's a rejection, you have acute kidney injury, you have a thrombosis, there's an obstruction, whatever that looks like. Your job is to keep looking at the patient and assessing to find. Nursing is proactive. If you're ever being reactionary, you probably failed to do something. I'm not saying that's always the case because people can crash like that, but rarely do people crash without you knowing about it. If you're being very proactive, if you're constantly assessing, if you're steadily looking for things, you will find exactly what it is you need. So there you go. We know that urine is pink and bloody right after surgery. It gradually returns to normal over several days and weeks. So be aware of that. These people might have a continuous bladder irrigation on. So think about people who have a TURP when they have that transurethral resection. Same thing here. Anytime you mess with the bladder or anything in that area, we know as inflammation or swelling, or if it starts to fill, it can cause the ureters to be compressed, which will prevent urine from leaving the kidney. And if we do that, we can cause kidney damage, right? So it might be something you see. Continuous bladder irrigation could be prescribed to decrease clot formation, because that would cause increased pressure in the bladder and endanger the graft. That's what I'm trying to get you to understand, is we have to be aware of what we have to be aware of and what that looks like. So if you're doing if you have continuous bladder irrigation going over and over, and the patient starts complaining of pain in their stomach, that could be a sign that it shouldn't be painful to have continuous bladder irrigation. Pain is typically a sign of something going on, a clot, distension. That's what I want you to pay attention to. So if they're doing continuous bladder irrigation, listen for signs and symptoms that there could be a clot and distension. Look at the belly, listen to the patient. All right, the catheter is typically removed as soon as possible to avoid infection, but 3 to 5 days after surgery so we can prevent swelling in that distended bladder. To increase urine output, the healthcare provider might prescribe a diuretic, some kind of osmotic agents to make sure that we're urinating. Closely monitor the patient's fluid status. Look for fluid volume overload, because fluid volume overload can cause hypertension. It can cause heart failure. It can cause pulmonary edema. All of these decrease blood flow to the kidney. So you're not going to have that good perfusion. You'll have rejection. Evaluate the fluid status by daily weights, by measuring fluid pressures every 2 to 4 hours. Look at the eyes and nose. We know that daily weights are the most accurate because a liter of fluid weighs a certain amount, right, each time of kilogram. So that's what we have you looking for. Instead of oliguria, they're not, things like that, the patient may have diuresis, especially if the kidney from a live donor, because they might be peeing a lot. They might not have ever got rid of all this fluid. So they get this live new kidney that starts working. They might be peeing nonstop. So you might see diuresis. So monitor the eyes and nose. Look for any kind of disruption in fluid electrolyte balance, too much or too little. Low potassium, low sodium levels, excessive diuresis can cause hypotension, which is also not going to perfuse your organs and your kidneys. Yeah, it's a balancing act. You got to constantly be monitoring for stuff. Monitor the patient for cues that there's hypotensive issues going on. We know this, right? Unanticipated urine output of 500 to 1,000 mLs greater than intake can lead to this, right? Think about what we're talking about. Hypotension reduces perfusion and oxygen to the new kidney. I've already said that. Monitor. If you see a normal blood pressure at 120/80 drop down to 90/60, you got to act. It is a sign that you're not perfusing anymore. And if that new kidney is not getting oxygen and nutrients, you will not have a great chance of the graft surviving. All right, y'all, that's all we have to talk about. If you have any other questions, please look up more information. Best wishes on your exam, and I will see you again here soon enough.